Our technology has also been used for biomarker assessment of target engagement, so more of a clinical application of this. Uh, this comes from a NASH area, so this is Rohit Lumba's work at UCSD, University of California, San Diego, where non-alcoholic steatohepatitis suffers from or results from dysregulation of de novo lipogenesis and decreased fatty acid oxidation. So the thinking is that liver fat is one of the steps that go on to pathological sequelae that relate to non-alcoholic steatohepatitis or NASH or decompensated liver function. So the idea is if you can block that liver fat from ever being produced, you can improve NASH and be able to treat NASH. So they focused on a specific target, acetyl-CoA carboxylase, which is a key enzyme that is involved or drives de novo lipogenesis. And it's known that there are some key markers of this enzyme that are malonate, malonyl carnitine, and beta-hydroxy beta-carnitine, and then butyryl carnitine that are known to be regulated or influenced by the function of this ACC enzyme. And so the first thing they did is characterize in a NASH population versus healthy controls, what do the levels change? Does the function of this enzyme correlate with what we'd expect from a disease profile? And you can see that 3 of these metabolites go up, whereas I think it's butyryl carnitine that doesn't change, but malonate, malonyl carnitine, and beta-hydroxy butyryl carnitine do increase in NASH relative to a healthy population, suggesting that this represents a good target to go after in terms of treating NASH. So we worked with them to do metabolic profiling on a specific panel of these metabolites to create a biomarker index from these, which is actually a ratio of malonate, malonyl carnitine over beta-hydroxybutyryl carnitine. And using this index that we were able to profile for them in this study, they're looking at healthy controls that were subjected to de novo lipogenesis. So this healthy control cohort was given labeled fructose to drive de novo hepatic lipogenesis, and the C13 incorporation into VLDLs was used to assess de novo lipogenesis. And in this healthy cohort, individuals where we characterized this biochemical index or metabolic index from these metabolites showed a strong correlation of increase in these metabolites versus de novo lipogenesis, the percent change in de novo lipogenesis, showing that this would be a good biomarker index to look at target availability and target engagement. And in the same population in a crossover study, they were either given placebo or the drug down here with this de novo lipogenesis that was tracked. And relative to the placebo group, you can see a marked decrease in the biomarker index for this, showing engagement of the drug for their specific target to decrease de novo lipogenesis. The question is this a relevant target for treating NASH? And that was in the second part of the study, or an expanded view that came after this initial part to look at target engagement. Does this actually have an effect in NASH patients? So taking this to the next phase of clinical development, they looked at 126 patients and treated these patients with this drug. There's 126 patients that have various degrees of NASH. So NASH is a spectrum of disease, of course, that is characterized by both liver fat as well as liver stiffness. So 2 imaging metrics were used to look at response to therapy. And there were 2 different therapeutic doses that were used, a 20 and a 5 therapeutic dose. And this is a liver-targeted oral delivery of this drug. And what they observed is that in the patients that responded, they saw sharp and profound decreases in, I only show 4 acetylcarnitines, but there is acylcarnitines, but there is a profound shift in acylcarnitines in the responder group at both doses that they saw. So that they actually developed a targeted panel of 22 acylcarnitines to be able to look at response to therapy from once they were able to assess that they were able to get biomarker target engagement. On all this showing good area under the curve for their responders. And this is important now because you can actually start to design rational trials. So you can understand who responds to a therapy, who doesn't respond to a therapy, stratify populations for efficacy or response, and now you're able to have data-informed rational design for clinical trials, larger clinical trials, to be able to understand the response, safety and efficacy profiles, and really be able to drive clinical development in a rational and designed way.